Hey everybody, welcome back to Neuroscience. Today we're going to switch topics and go right into optic anatomy. So, the visual system is the most sophisticated in humans. We are visual creatures. The visual field is pretty wide because of the two overlapping regions, right? So we have the nasal region along with the temporal region. And there are two decussations. There is going to be decussations in the field of vision, as you can see here, like right in the actual retina itself, and at the optic chiasm. So within the retina is your rods, cones, bipolar cells, and the optic ganglia, and all of that is going to be, all the information is going to be like transferred and interpreted in the Meyer's loop. And the Edinger-Westphal nucleus is going to connect to the pretectal nucleus, and that forms like the light reflex, which we will go through later. The pupil reflexes, really. The Argyll-Robinson pupil will occur if the lesion is in the pretectal nucleus. We will go through that as well. So the tunics, the outermost is going to be your fibrous tunic, and it's going to be made out of both the sclera and the cornea. The intermediate, or the vascular, or the uvea, is going to be made out of your iris, your ciliary body, and the choroid. The retina is going to be your pigmented layer, and it's going to be your neural layer. The cones lie within your choroid layer, and that's a nice kind of like memorization technique. Cones, choroid. The retina is going to be made out of two layers, three layers really. The outermost layer is going to be your rods and cones, then your bipolar cells, and then lastly your inner ganglionic cells. The pigment layers are kind of attached to the choroid, but not very tightly, so they're really attached to the neural layer. Thanks to that, loose attachment, if you get punched in the eye hard enough, any kind of like eye trauma, you can have something called retinal detachment. And here, as you can see, there's going to be a shift where the inner pigment layer, the outer pigment layer isn't going to adhere or line up with the choroid or with the neural layer. So the rods and the cones are your modified neurons. The outer portion is light sensitive. The inner portion is going to have the photopigments. The rhodopsin is your photopigment in rods, and those are usually in the periphery of the retina, so that's your best low light vision. And iodopsin is going to lie in your cones. Cones are in the center of your retina. Cones are for your color vision. The bipolar cells are going to connect the ganglionic cells by the amacrine cells, and they're going to connect to the cones by the horizontal cells. So the ganglionic cells are multipolar cells that eventually merge to form the optic tract, or the optic nerve fiber, either or. Here are your ganglionic cells, here's your bipolar cells, rods, cones, and here's your pigment epithelium. Pigment epithelium is like the colored portion of your eye. Okay, so the other structures, important to know, optic disc. This is where your optic nerves fibers exit, so this is not going to respond to light. It's going to run with the central artery of the retina and the central vein of the retina. So these are the only two structures besides, the optic tract that run through the eye, through the hyaloid canal. That's what it's called. So you use this to look for glaucoma. So, like I said, there's only one canal going through the eye, and the optic tract is going to be compressed if the optic vein and the central artery is going to be enlarged due to the hypertension. The macula lutea is aligned with the visual axis, and it's yellow because of the xanthophyll in it. And in the very center is going to be your fovea centralis, where there's only cones. So this is where your most accurate vision is. So, of course, the most accurate vision is going to be the center of your vision, not the periphery. The ophthalmoscope is going to be used to observe the fundus, and there you can see the optic disc or macula. That should be yellow. The veins should be pretty thin, and in optic atrophy, the optic disc is going to be white. So you know there's going to be some kind of problem with the nerves. The fovea is a little dark spot, which is completely normal. Cataracts are the clouding of lens, and it can lead to blindness. It can be due to opacification due to the loss of elasticity of the lens, or it can be due to some kind of congenital infection, poor development, malnutrition. It can also be due to exposure to radiation, diabetes, and medication, along with trauma, of course. Okay, so glaucoma. It's going to be a high intraocular pressure due to the buildup of aqueous humor in the anterior cavity. And there are the inflammatory glaucoma types, the neovascular glaucoma types, and the traumatic glaucoma types. All of that is due to like the buildup of hypertension. The fluid will compress the lens and put pressure on the neurons of the retina. And then the swelling of the retinal artery and vein will compress the optic nerve, of course, as you can see here. Accommodation is like basically how we are able to switch from far vision to near vision. The ciliary muscles will contract and pull the ciliary body to release the tension. So the rounder the lens, the closer the focal point. So the refractive area, the problems will lead to nearsightedness, farsightedness, or both. Astigmatism is when an asymmetrical lens is going to have like multiple focal points. The lens system is made out of the 4 refractive interfaces, so it's like the air, and then the cornea, then the aqueous humor, then the lens, and then the vitreous humor. So the inner segment, the cells are going to have the nucleus and the organelles for the synthesis of the photopigments and the production of ATP. The outer is going to be the visual pigments embedded in all these like folds and discs, and these discs are going to be made from the base of the outer segments. And the old discs at the tips are going to be phagocytosed by the pigment epithelial cells. The transduction of light is going to occur in the outer segments, of course, because this is where the visual pigments are. And light comes in and makes a conformational change from a cisretinal to transretinal. PDE is going to be activated from G protein, and GMP is made, so cGMP falls. As that falls, the sodium channels close and hyperpolarize. Then in darkness, there's going to be an increase of cGMP, and depolarization happen because of the influx of sodium and calcium. So the regeneration of the Levin's retinal is going to need vitamin A. We need the cisretinal because there is night blindness. So a less amount of opsin and retinol in the rod. So there's going to be first a loss of peripheral vision, and there's just like not enough C retinol around. So it needs a lot of light to stimulate the receptors. This is going to be treated by oral supplements of vitamin A. So like, what is night blindness actually? It's just when when a patient is in a dark room and then all of a sudden like a bright light is flashed, for a normal person they're able to like see the bright light and the eyes are able to hyperpolarize, but in somebody with night blindness they are not able to, so everything is still dark. Clearly this is a problem, especially if you're going to be driving at night. Okay, so bipolar neurons. Hyperpolarization is going to decrease the release of glutamate, and the decrease in inhibition of the metabotropic receptors is going to cause the excitation. So, decreasing the excitatory glutamate response of the ionotropic receptor is going to inhibit the bipolar and horizontal cells. On bipolar cells is depolarized when there is light. glutamate is decreased, and the off bipolar cell is hyperpolarized. This is a graded potential, so this is not just all or nothing, right? So they can build. The off bipolar cells is going to be depolarized in darkness, and the on bipolar cell is going to be hyperpolarized, and that is going to be inhibited by glutamate. So when glutamate is released, the on bipolar cell is going to be hyperpolarized in light, and the firing of the on ganglionic cell is decreased, and then the other side has to be coordinated, right? So both cannot be on. So why is this important? What is the graded potential, right? So this allows you to see light in like all directions. So in this particular case, the center is going to be predominantly the off bipolar cells, right? There's not going to be any light. So the on bipolar cells are going to be hyperpolarized, and the off bipolar cell is going to be depolarized. Well, in this case, the on bipolar cell is going to be depolarized, and then the off bipolar cells are going to be hyperpolarized. So horizontal cells will inhibit the bipolar cells by hyperpolarizing. So these are going to also play a role in receiving input from multiple photoreceptor cells, and they all integrate the signals from different population of the photoreceptor cells, allowing you to see like the details of scenes. The amacrine cells, on the other hand, are excitatory, and they receive signals from the bipolar and the ganglion cells. Okay, so visual acuity is basically like the sharpness of your vision. Test it by your Snellen letter charts, one eye at a time, to see the binocular vision. Color vision works best in the wavelengths of 450 to 700 nanometers. We use something called the Ishihara charts, which are these, to test for your color vision. So color blindness is X-linked, so unfortunately in males, and there's several different types. Monochromacy is going to lack about 2 out of 3 of the cone types, and dichromacy is when you lack only 1 cone type. Lack of blue cones is going to cause tritanopia. Red is going to cause protanopia. Green is going to cause deuteranopia. So if you lack one of the colors, you're going to see the compensation much higher. So in Deutin color blindness, like they lack the green color, right? But you can see here there's like there's still like the pink showing through, so you can still see red. Anomalous trichomy is going to be defective light cones with absorption spectra which is within the normal ranges, and there's just not enough of the cones, right? So they are normal. These patients just don't have enough of them. That's it for your attention. Thank you, and good luck studying.